Hello everyone, welcome back to my channel. Here I would like to discuss about the anatomy of urinary bladder. It is a hollow muscular membranous structure which is acting as reservoir of urine. It is the most anterior element in the pelvic viscera. Urine enters the bladder via ureters and exits via the urethra. The anatomical location of the bladder is, when empty, in adult urinary bladder it is located in the lesser pelvis. It is lying partially superior to and partially posterior to the pubic bones. As the bladder fills, it enters the greater pelvis. In some individuals, a full bladder may ascend to the level of umbilicus. In infants and young children, urinary bladder is in the abdomen. When empty, the bladder usually enters the greater pelvis by 6 years of age. Here we can see the normal anatomical location of the urinary bladder in the lesser pelvis. And this is the sagittal section of a newborn female child where we can see the abdominal location of the urinary bladder. Now the parts of bladder. Bladder has been divided into two main parts, that is body and the neck. Body is the major part in which the urine collects, and the neck is the funnel-shaped part that connects the bladder with the urethra. Now the presenting parts of urinary bladder. It possesses superior surface, right and left inferolateral surfaces, posterior surface or base, and the apex. There are three borders in the bladder: anterior border, which is between the apex and the neck. It divides the two inferolateral surfaces. Posterior border separates the superior surface from the posterior surface, and the lateral borders separates the superior surface from the inferolateral surface. Now the body of urinary bladder. It is lined with transitional epithelium. It can hold 220 ml of urine. The sense of filling starts when the urine reaches up to 150 ml. The physiological capacity to hold the urine without undue discomfort is up to 450 ml. After 450 ml, painful sensation starts, and the urine when reaches beyond 800 ml, we cannot control voluntary the passage of urine. So this green colored area denotes the body of urinary bladder. In this we can see the neck of the urinary bladder, which is the lowest portion of the bladder through which the urethra arises. It is the fixed part of the bladder. Now the fundus of the urinary bladder. It is the base of the bladder and it has the shape of inverted triangle. It faces posterior inferiorly and formed by the posterior wall of the bladder. Trigone of the bladder is found on the fundus. In this we can see the interior of the fundus, where we can see the triangular area which is known as trigone. Now the relations of the fundus, that is posterior inferior surface. In males, it is related in the upper part with the ampulla of the rectum. Here we can see the ampulla of the rectum, and the lower part is related to the seminal vesicle. This is the ampulla of the rectum, and in the lower part we can see the seminal vesicles and the vas deferens. Also rectovesical fascia of the non-biliars, which is separating the urinary bladder from the rectum. In female, it is related to the anterior vaginal wall and the anterior surface of supravaginal part of cervix. Then the superior surface of the urinary bladder is related with the peritoneum and sigmoid colon and coils of intestine. So these are the coils of small intestine, and in case of females it is also related with the anteverted uterus. The inferolateral surfaces, each surface is directed downwards and laterally, and mostly they are non-peritoneal. The relations on this, we can see the pelvic surface of the body of pubis and pubic symphysis, also the fascia covering the levator ani and the obturator internus muscle. Then the space of Ritzius. This is a horseshoe-shaped potential space which intervenes between anterolateral pelvic wall and the sides of the bladder, as we can see in the diagram. It allows distension of the bladder. Now the boundaries. Anteriorly, it is related with the pubic bones and pubic symphysis. Also, we can see posterior side, the posterior true ligament. Above it is related to the peritoneum. Medially, it is related to the inferolateral surfaces of the bladder and the prostate. And laterally, it is related to fascia covering the levator ani and the obturator internus muscle. The lateral relations are shown in the diagram below. Now the contents of retropubic space or space of Ritzius. They are retropubic fat, vesical venous plexus of veins. What is the importance of this space? The importance is that surgical approach to the bladder and prostate can be done in case of bladder distension. Now the interior of urinary bladder. On the inside, we can see a trigonal area on the fundus, that is the trigone of urinary bladder. It is a smooth triangular part of bladder. The mucosal lining of the trigone is smooth and firmly attached to the underlying wall of the bladder. The boundaries include the apex, which is directed downwards towards the neck, and the base is between the two openings of the ureters, that is the Mercier's bar, and the lateral sides, which are known as ureteric lines. They are forming the lateral sides of the trigone. Once the trigone of urinary bladder is stretched to a certain degree, signal is sent to the brain that the bladder needs to be emptied. Now the importance of trigone. It is the most fixed and dependent part of the bladder. It is richly supplied by the blood vessels and the nerves. Developed from mesoderm, whereas the rest of the bladder develops from the endoderm. Now the urethral orifice. Urethral orifice, we can see these are the slit-like openings through which the ureter enters the bladder on the posterolateral angles of the trigone of the bladder. Now the Mercier's bar. It is a mucous membrane present between the two urethral orifices. It is also known as interurethral fold. This is highlighted in the diagram below. Now the internal urethral sphincter. It comprises of smooth muscles that is located at the junction of urethra and the urinary bladder. It is innervated by S2, 3, 4 spinal nerves of the pelvic plexus. Its function is to constrict the internal urethra, preventing the urine leakage, and also prevents the retrograde ejaculation, that is ejaculatory reflex of semen into the bladder. Here we can see the internal urethral sphincter, which is made up of smooth muscles surrounding the opening of bladder to urethra. It has involuntary control, so we cannot control the internal urethral sphincter. In this, we can see the external urethral sphincter, which is made up of skeletal muscle fibers surrounding the opening of the urethra outside. This having voluntary control. So here we can see the internal urethral sphincter, which is highlighted with green color. This constricts the internal urethra and prevents the reflux of semen. Now the detrusor muscle. It is also known as muscularis propria. It is a smooth muscle which is found in the wall of the bladder. It comprises of inner and outer longitudinal and middle circular layer. This muscle is relaxing during accumulation of urine in the bladder and contracts only during urination to void and empty the bladder. So here we can see the highlighted area, which is the detrusor muscle, which is the main smooth muscle forming the body. Now the supports of urinary bladder. It includes the ligaments. The ligaments which support the bladder, they have been classified into two groups, true and false. True ligaments, these are formed by the thickening of pelvic fascia. These are lateral true ligament. In the diagram we can see the lateral true ligament is attached from the side of the bladder to the lateral pelvic wall. Posterior true ligament, this is attached from the lateral borders of the base of the bladder to the lateral pelvic wall. The medial and lateral puboprostatic ligaments, they are attached from the body of pubis to the prostate. They are lying on the anterior aspect, we can see in the diagram. In the diagram, this is showing the superior view of the pelvis, in which pubic symphysis is lying anteriorly and sacrum lies posteriorly. In the pelvic cavity, we can see in front, this is the urinary bladder. In the middle, we can see the cervix, and the posterior most structure is the rectum. Then the median umbilical ligament, it is formed by the urachus. So in this diagram we can see the urachus, the median umbilical ligament, which is connecting the apex of bladder with the umbilicus. Now the false ligaments, these includes the median umbilical fold, which lies in the midline. We can see the median umbilical fold. This is the formed by the fold of peritoneum over the urachus. Then medial to it we can see the medial umbilical fold, which is a peritoneum covering over obliterated umbilical artery. And this is the lateral umbilical fold, which is the peritoneal covering over inferior epigastric artery. In spite of this, we have the posterior false ligament. So these are the posterior false ligaments behind the bladder. This is the male pelvis, where we can see the sagittal section of bladder and its relations. This is the female pelvis, where we can see the sagittal section of the bladder and its relations on the anterior and the posterior sides. Then the arterial supply. The bladder is supplied by the branches of internal iliac arteries. These are superior vesical and inferior vesical arteries. Inferior vesical artery in case of females is replaced by vaginal artery. Also, obturator and inferior gluteal arteries also supply the bladder. So here we can see the numerous arteries which are supplying to the bladder. Then the venous drainage. The veins draining the bladder corresponds to the arteries. Veins from the vesical venous plexus drain into internal iliac veins. Now the innervation of the bladder. The nerve of emptying is the pelvic nerve, which comes from parasympathetic nerves of the sacral region. It is not under our control. It causes contraction of the detrusor muscle. The nerve of voluntary control is the pudendal nerve, which is a somatic nerve. It causes contraction of external sphincter. We are firing pudendal nerve when we are trying to hold our urine. Then the nerve of filling is the hypogastric nerve, which is coming from T11 to L2 segments, that is the sympathetic nerve, which causes relaxation of detrusor muscle and contraction of internal sphincter. So here we can see the sympathetic, parasympathetic and the somatic nerve innervation of the bladder. Then the lymphatic drainage of the bladder. In both sexes, the lymphatic vessels leave the superior surface of the bladder and pass to the external iliac lymph nodes. Those from the fundus pass to the internal iliac lymph nodes, and some vessels from the neck of the bladder drain into sacral and common iliac lymph nodes. Now come to the applied. First is uninhibited bladder. The causes include cerebrovascular accidents, head injuries and brain tumors. In this, the voluntary control of micturition is lost. Then the reflex bladder. It caused by the complete transection of spinal cord above the sacral segments. It causes voluntary inhibition and initiation of micturition. In this, these voluntary activities are lost. The bladder empties reflexly after every 1 to 4 hours. Then sensory paralytic bladder. It is because of pernicious anemia and diabetes. The lesion occurs by the afferent fibers from the bladder. It causes loss of bladder sensation, which leads to overdistension of the bladder. Then motor paralytic bladder. It causes painful distension of the bladder and inability to initiate micturition. Then incontinence of urine. The term continence is used to describe the normal ability of a person to store urine and feces temporarily with conscious control over the time and place of micturition and defecation. The incontinence has been defined as the involuntary or inappropriate passing of urine or feces or both that has an impact on social functioning or hygiene. Then nocturnal enuresis during sleep or bedwetting. This occurs in 15 to 20% of cases of 5-year-old children and up to 2% of young adults. It has been divided into 2 types: primary nocturnal enuresis. In this, bedwetting persisting from early age due to delayed maturation of voiding mechanism. Secondary nocturnal enuresis. In this, the wet's bladder bed after remaining dry for variable period with an underlying cause of UTI, diabetes mellitus, renal abnormality and failure. Then we have cystoscopy. It is a procedure to view the interior of bladder with the help of cystoscope. Here we can see the formation of stone in the urinary bladder. Then the trabeculated bladder, it is a hypertrophy or thickening of the smooth muscle of the bladder wall. Then the cystitis, it is the inflammation of the urinary bladder which is caused by any infection. So this completes our topic urinary bladder. Thank you.